This may be an issue again tonight, and I planned the whole thing. I really did. I made sure you were all here for it. And I had him close the air wall because I know it was getting a little bit crazy. So we're going to have a break in a little while around the corner. Our next speaker is Dr. Sara Frederico. She received her bachelor's degree at Stanford University in California and her MD at Virginia Commonwealth University Medical College. She did her internship and residency at Lucile Packard Children's Hospital at Stanford University and her fellowship at St. Jude. She is author and co-author of numerous publications and articles, and her research interests are clinical investigation of pediatric soft tissue sarcomas, translational research in pediatric solid tumor cancers, and novel drug development for pediatric solid tumor malignancies. She's here today to talk about the trials that are currently going on at St. Jude. Dr. Sara Frederico.
All right, good morning. I'm short. Hold on. There we go. Okay, so it's so great to be here. I actually was here a number of years ago and then in San Francisco, but it's really fun to be back here. And so I appreciate the opportunity to share some of the work that we're doing at St. Jude and then just general through some of the consortiums. So I have no conflicts of interest or no financial disclosures. And so a little bit about me. When I did my fellowship, and this is really a sign of hope, because when I did my fellowship, I started in 2007, and I finished in 2011. And these two kiddos, the fireman and the dancer, were my inspiration. And so they taught me about high-risk neuroblastoma. They gave me passion that we have to advance the field, we have to do better. They deserve it, the families deserve it. And so that really just got me committed to making sure that we advance the field. And it's exciting that, I'm not like 100. It hasn't been that long, but there actually have been improvements in outcome since my fellowship, which is really exciting. We still have a long way to go. And then once we figure things out a little bit better, then we need to be able to dial things back to limit toxicities like Dr. Desai just mentioned. And so Dr. Desai just talked about multimodal therapy for high-risk neuroblastoma, which is what I'm going to focus on. And really, I call your attention to the left hand of the slide to also highlight the fact that everyone's been working on this collectively for a long time. And so even though individually we're going to get up here and present our different research and talk about kind of things that are going on at our institution, this field is really a group of folks that collaborate to try and move things forward. But we obviously ended on the right-hand side with, unfortunately, children who have high-risk neuroblastoma requiring a lot of therapy in order to move that survival and cure rate up. And there has been incremental progress in time. And so as Dr. Desai just mentioned, on the left hand of the slide, the low and intermediate risk group survival curves have moved up significantly, and we've been in a place where we're able to dial back the amount of therapy that's been administered to these patients. But actually, the high-risk survival curve has also been moved up. And so I appreciate Arlene Naranjo actually just updated this slide recently, so it has some of the more modern era treatment. The numbers are a little bit hard to see, but essentially these curves are going up. So when you look at a Kaplan-Meier curve, basically on the y-axis is survival. So what we want is a flat line, 100% across the top, and then the x-axis on the bottom is time. And so you can see that over time, as we've tweaked the medications and the regimen that we give to our patients with high-risk neuroblastoma, we have improved outcome. And as many people know, that one of the biggest jumps in this past decade from when I started my fellowship to where I am now was really the addition of dinutuximab, so that antibody to the end of therapy. And this improved outcome by 20% and event-free survival. And so I'm a visual person, and so like neuroblastoma tumor cell, right, flag, right here, my thumb, GD2. We give antibody, it circulates around the body, it's looking for GD2, it binds it. That does not kill the tumor cell. Then what we need to do is rev up the patient's own immune system, and so now the immune system recognizes that, and now your own immune system can kill the tumor cell. And so the addition of dinutuximab, the antibody, anti-GD2 antibody, to the end of therapy improved outcome. But it's also important that when, as physicians, I'm totally guilty of this as well, when we walk in and we're talking about data and we're giving you information, it's also important to know, what are the different time points and what does that mean? So when we look at this survival curve, and it definitely was better with the addition of dinutuximab, that time point on that trial, Dr. Yu's initial antibody trial, started for the patients who made it through induction and through consolidation and were able to get antibody. And so what it doesn't take into account is that there were patients during induction or during consolidation that may have had progressive disease, may have had to go off therapy for toxicity, or who may have just had not a good enough response to be able to be eligible for the trial. So it's really important to always talk with your physician and ask them, when you're giving me numbers, what is our time point that we're talking about? And so actually when we look at that very seminal paper, so this study that added dinutuximab to the end of therapy, when we look at that patient population and try and get an idea of what is their true 3-year EFS, again, we always use too much jargon, so event-free survival, which means when you get to 3 years, have you relapsed or not, or had a second cancer, there are other events, but the big one that we kind of think about is relapse. And so for patients treated on this study, the most recent COG trial, the 3-year event-free survival was 51%, meaning that at 3 years, about half of the patients had had an event, either relapse, passed away, second malignancy, or they hadn't. And so there are a ton of targets, and I'm not walking through this, I promise you. The bottom line, the reason I bring this up is that there are so many ways that we can attack neuroblastoma, and actually many of the different speakers that are going to talk over the next couple of days are going to kind of focus on their aspect, and so that's what I'm going to focus on today right now is anti-GD2 monoclonal antibody therapy, but recognizing that there are a lot of people that are working very hard at attacking the cancer in different ways. So we're going to focus on the little red box, which is that antibody therapy. And so at St. Jude, we've been doing clinical trials using a different monoclonal antibody. It's called HU1418K322A, which is obnoxious, so I'm just going to call it HU1418K. And what it is it's similar to dinutuximab. Again, the mechanism is the same, right? Tumor cell, antibody, goes around your body, it's looking for this flag, binds to it, and then we rev up your immune system by giving things like GM-CSF, that then your own immune system can fight the tumor cells. So this antibody that we have been using and studying at St. Jude, it's humanized, and so that means it has less mouse in it, so it's less immunogenic, meaning you're not going to probably have as many allergic reactions to it. It does have a single point mutation in the arm of the antibody because we all know that antibody comes and can cause pain, and so scientists were able to figure out, well, what's really triggering that pain, and can we change that but still allow the antibody to bind well? And so it theoretically has less pain. It's produced in a different cell line, which may improve how well it works. And again, may is important. And then ultimately, because patients tolerate it better, we have been able to give higher doses of it. It's really important, though, to disclose, nobody knows that, right? So sometimes people will get up and we can talk about the fact that we can give higher doses, but I actually don't, and we can, of this antibody, but I actually don't know if that's more is better. It might be, but it might not. And so there were a couple of studies that were conducted within the past decade. So the first, as Ami was talking about, when you're trying to evaluate a new agent, you need to figure out, can I safely give this to our patients? And what are the side effects, and determine the dose? And so that was a phase 1 study that was published in 2014 that basically said when you give antibody by itself without anything else to patients who have relapsed or refractory neuroblastoma, so relapse meaning it's come back, refractory meaning it never went away, can they tolerate it? And so in that trial, demonstrated that, yeah, patients can tolerate it, again, with appropriate medicines to manage pain and allergic reactions if they had them. And importantly, there were some patients that when they received it by itself had a response. And so a CR means a complete response, meaning all your cancer has gone away. A PR means a partial response, and there's this really complicated system that we all keep changing, but basically means some of your cancer has gone away. And we determined the dose to use. So the follow-up study to that was a pilot study looking at the combination of that antibody, the HU1418K, with different combinations of chemotherapy that are that are frequently administered to patients in the relapse or refractory setting. And again, the goal at that point in time, which we now all know the answer to, but the goal was really to see, can you combine antibody with chemotherapy? Is it tolerated? And then more importantly, does it work? And so this was just a small pilot study to look at the feasibility of giving chemotherapy with antibody therapy. And we were very happy to see that actually it was feasible, so you could do both. And then patients were responding. On this trial, we only gave 6 cycles, though, of the therapy. So there were 3 patients out of 13 that had a complete response, meaning their cancer went away entirely, 1 patient that had a VGPR, meaning most of their cancer went away, and 4 that had a partial response. And when we think about what that means and comparing it to other trials that have come along in the past before chemoimmunotherapy studies, usually, like, many trials would be considered like, oh, that's pretty good if about 15%, unfortunately that's where we're kind of at, 15, not 50%, had responded to therapy. That was kind of preceding this chemoimmunotherapy time point. And then importantly, for the patients that unfortunately had relapse and their cancer came back, there was this prolonged time period before their cancer came back. And so Wendy London, who I don't know if she ever presents here before, but she's a statistical genius in the neuroblastoma field. So she and others, colleagues, wrote a paper, looked at all the different phase 1 studies, and found that the typical time for after a clinical trial, if your cancer's come back, is about 61 days. And so this was longer than that. Again, tiny patient population though, right? And so these are the important things. I love that Dr. Desai brought this up, because when people are talking with you about data, I always point this out. Small group of patients. I don't know, wasn't randomized, but a signal, and you'll oftentimes hear oncologists talk about a signal of activity, and that it should be studied further. And then when we were coming up or seeing those results as well, this was the important AMBL 1221 data of Dr. Modi. I know he's come here a number of times and presented this data that really showed that when you combine irinotecan, temozolomide, so 2 chemotherapies, with dinutuximab, the chimeric antibody that we use in the upfront setting, in patients who have relapsed, their cancer's come back, or refractory never went away disease, that 53% of them had a response. And this was in comparison to a different patient arm, so randomized trial that got same chemotherapy, dinutuximab, irinotecan, but then another chemotherapeutic, temsirolimus. And so that group of patients, only 6% of them responded. And so when clinical trials are designed and they're ongoing, they actually have all these different time points where we stop and take a look. Well, usually, if they should, most of them do. Where the statistician then stops and takes a look, like, is there a home run? Are we causing harm by giving these different treatment combinations? And so at an early time point when they saw this response, 53% compared to 6%, they said, well, we can't let this study keep going on. Everyone now just needs to get the 53%. And so then the trial was expanded to allow patients who continue to enroll in that study to get irinotecan, temozolomide, and dinutuximab. And when they looked at those overall response, they found that patients, the response rate was more like 40% of patients had a CR/PR, and the other 40% had stable disease, meaning that their cancer had not progressed. And so again, this really moved the bar. And so people will oftentimes refer to this as chemoimmunotherapy, and so that's what I'm talking about. And so around the time that all of this was going on, our goal at St. Jude was always to try and get chemoimmunotherapy into the upfront setting to see if it would work for patients. And this really came out of when Dr. Yu presented her initial work that showed antibody at the end of treatment, improved outcome for patients. Then Dr. Furman, who has since retired, went up to her and was like, well, we got to get this into patients at the time of diagnosis. And so that's what this study was. So this trial was called MB 2012, and it was published last year. And really it was looking at, can you give chemoimmunotherapy during induction, the first part of therapy, and is it safe and tolerable, but does it improve outcomes? So are more patients able to get rid of their cancer and have it not come back? And so in this trial, I want to point out that the recipe was a little bit different than what we typically use in the COG trials. And so in the current COG trials, we actually use 5 cycles during induction instead of 6. This was, at the time it was written, that's kind of what was being done. And so we were using historical control, so that's why we use 6. The consolidation, so that's the transplant. At the time the trial was written, we did not have the results of Dr. Park's trial that showed that tandem, meaning 2 transplants, was better than 1. And so the results that we had, we looked at the results in the US and the results in Siopin, so that's basically the COG equivalent in Europe. And they had shown that the chemotherapy called Bumel was maybe better than what we were using. So the consolidation was a little bit different, but you still got a transplant. And then at the end of treatment, instead of getting dinutuximab, the patients received the humanized antibody that they also got in the front. And then what we did is we added that humanized antibody, that's the HU, to each cycle of induction therapy. And we knew that, this is toxic treatment, and we need to be able to identify a signal of activity. Again, this is a single institution, just done at one site. We're looking for a signal. We're not trying to prove that it works. We're looking for a signal of activity. And so what we did is we wanted to look at that, see where that arrow is. The arrow is pointing at response after 2 cycles. And the reason we were looking at that time point, looking for an early signal, is that we could compare it to what's called a historical control, which means if you look at prior trials that have been conducted, you're not randomizing the trial, but you're trying to take the best data that you have available. What was that response rate, and can we improve on it? And so there were 2 prior clinical trials. Actually, there was 1 prior clinical trial, and then the tandem transplant trial results came out, which showed the same, which is that after 2 cycles of induction therapy, cyclophosphamide and topotecan, the response rate was 40%, meaning patients had a partial response or better. And so in this clinical trial, what we were looking for is improving on that by 20%. And so we said, well, we don't want to add a bunch of toxic therapy to the patients unless we see a 20% improvement at that time point. And so we set our bar at 60%. And so the first 42 patients were enrolled, again, single institution, and what we found is after those first 2 cycles of therapy, so same chemotherapy as the historical control, cyclophosphamide topotecan, the difference was adding the antibody therapy. Our response rate, meaning partial response or better, that we saw was 76%. And so this really was a signal to us that actually we really need to expand the trial a little bit and be able, if we can determine what the 3-year event-free survival, which a lot of times, and what Dr. Desai was just presenting, that's kind of a mark that a lot of us look at, and we have a lot of data on 3-year event-free survival. So we added some more patients to the study. And what we found is that there was a dramatic response to induction. And so induction is the chemoimmunotherapy. Busy slide, sorry about that, but I'm gonna I think even if you cross your eyes, you can get an idea. So the first one is when we talk about response in high-risk neuroblastoma, like Dr. Desai just mentioned, we're looking at different components of response. So what does your first tumor look like? What does your bone marrow look like? And then what do these metastatic sites of disease look like? And we get response in each of those, and then we put them together and come up with an overall response. And so this slide kind of captures those. So this is after 2 cycles. The bar shows a dramatic decrease in their primary tumor size. Down is good, the very bottom being 100% of your primary tumor is gone. The colors show what your metastatic disease did. And so blue and red are good. That means a CR, VGPR, and actually even the green is a PR. That's also good. And then bone marrow, you can't really see here. It's there, the letters on the bottom. And what we found is after the first 2 cycles that there were we beat that more than 20% improvement. And then really when we got to the end of induction, which we're starting to learn more about, that this might be an important time point when we are thinking about, what do we do with next therapies, that actually many of the patients had a very, very good end of induction response. And so 60 of 62 patients had a PR or better. And actually, Dr. Desai and some of the colleagues in the room looked at metastatic CRs, like did your metastatic disease go away at that time of end of induction, and found that might be a good surrogate marker of how you do overall, but it's not the only thing. And so this was exciting to us and definitely to the field. And so that's where we are. Importantly, about 10% of patients who are treated on high risk historically, who have been treated on high risk neuroblastoma trials, may experience progressive disease at 7 to 10%, depending on which group of patients you look at. And in this group of patients, none of the patients had progressive disease. I mean, their cancer did not get worse during therapy. And so these 3-year event-free survival, so again, when you get to 3 years, has somebody had an event, which includes relapse, passing away, or secondary malignancies, was 73.7%, and the 3-year survival was 86%. And so, again, an important signal that maybe chemoimmunotherapy in the induction setting is something that should be further evaluated. And so our conclusion was that the addition of HE1418K to induction chemotherapy had improved outcome and should be validated going forward in a randomized clinical trial where you can really treat people at the same time and see, does your treatment do better than the current standard of care? So what does that look like? Again, historical controls are like fraught with issues, and that you just need to know that when people are comparing things. It's not the same as doing a randomized controlled trial, but it's what we have. So again, you can look at things for signals of activity. So in the blue circles, or I should say in the bottom red box is 3-year event-free survival. In the blue circles, those are the 2 most recently completed COG studies where the 3-year event-free survival is 51 or 55%. In the purple boxes, those are in circles, those are the 2 most recently completed SIOPEN trials. So again, kind of like the larger consortium equivalent in Europe that showed that the 3-year event-free survival is 34 to 40%, depending on which study you're in. And then our 3-year event-free survival is 73.7%. But again, single institution, not randomized. So it kind of bugged me, actually it didn't kind of bug me, it really bugged me when I was treating all these patients at St. Jude and seeing responses and was so excited, and then it really bothered me that that antibody wasn't available to patients everywhere. And so in working with colleagues in the Children's Oncology group, the commercially available antibody was dinutuximab, and so we wrote a trial called AMBL17P1, which was a pilot study looking at, can you add dinutuximab to chemotherapy for patients with newly diagnosed high-risk neuroblastoma, and is it tolerated? Again, it's a different schema, though, in that the patients here receive 5 cycles. That's because of some work that was done that showed that 5 versus 6 induction chemotherapy cycles still leads to the same end of induction response. And then we didn't actually give the dinutuximab, the antibody, with all the cycles of chemotherapy. And that was intentional in that at the time this trial was being written, a lot of patients now receive chemoimmunotherapy. A lot of hospitals have experience giving chemoimmunotherapy, and just the expertise, and the bedside nurses are amazing at managing symptoms. But at that time that this was written, there weren't that many patients that were receiving chemoimmunotherapy. So as a cooperative group, we were concerned that if we gave antibody therapy, especially in the first cycle of chemotherapy, that those patients, when they come in, can be so sick, were we going to cause more harm if all of a sudden they had fluid going to places they didn't need to have fluid and having a bad response to antibody, and would we cause harm? So that's why we added it to cycles 3 through 5. The other reason we didn't include cycle 2, I didn't talk about that, is just that we wanted to make sure that we didn't, most of the time at most centers, your stem cells are collected after the second cycle of therapy. And so we didn't know if that would affect it. And so that's why it was in cycles 3 through 5. So these results, or this study was conducted at 9 different centers, both in the US and outside of the US. And the toxicities we saw were expected, kind of normal dinutuximab toxicities. Patients were able to receive the antibody therapy in cycles 3, 4, and 5. And so that was important because it's a feasibility study. Can you do it? And then we're still working on the kind of longer term results. Hopefully the results will be out in the next year or so. So what we concluded on this trial was that you can give dinutuximab safely to patients with newly diagnosed high-risk neuroblastoma in different treatment centers in cycles 3 through 5. And so again, the question is, you're probably already tired of hearing about randomized trials, but I'll keep saying it. The question is, how can we best truly answer whether or not chemoimmunotherapy improves outcome for our patients with high-risk neuroblastoma? And the answer is that you need to assess it within a randomized control study. So meaning that patients will compare it to the standard of care, and other patients will get chemoimmunotherapy. And so this is a trial that's coming. So this is called AMBL 2131. Hopefully, it should open later this fall when the current COG trial closes. And it is asking the question of if you give antibody therapy, so in this case, dinutuximab, with induction cycles 2, 3, 4, and 5, with all the other standard COG backbone, then will more patients be cured of their cancer? And so this is a treatment schema where patients go on study at the top. They all have their tumor sequenced, and while they're getting their tumor sequenced, they receive the first cycle of chemotherapy, and then they are randomized, meaning a computer selects which treatment arm they go to. Treatment arm A is the standard COG backbone. That's the one that does not have a box around it. And then treatment arm B is the experimental arm where we're adding antibody therapy to induction cycles 2, 3, 4, and 5. Now, we didn't want to, some people have asked, like, well, you just presented some results that show when you give chemoimmunotherapy at your institution that you had an improved outcome, and is this equal, and should you be doing this? And so what we decided is that we want to still make sure that patients can receive chemoimmunotherapy on the clinical trial if they are having a poor response during induction therapy, because many patients who have a poor response during induction therapy or may unfortunately have their disease progress during induction therapy oftentimes go on to receive chemoimmunotherapy. And in this case, these patients would stay on study and have the option of receiving chemoimmunotherapy. And then if they had a good response, they would loop back into the rest of the standard treatment. And so again, this trial, this is the study team. So Thomas Cash from CHOA, who some of you probably know, he and I are co-chairing it. And then our vice chairs are Naveen Pinto, who will be in Colorado in like a week, and Carrie Strebe are the vice co-chairs. And so that's coming. I don't know any results of that because we haven't opened the trial yet. And so as all of this has been going on, one of the things that I wanted to focus on is just, can we build upon this chemoimmunotherapy backbone to try and improve it? And so a few years ago, again, tumor, flag, GD2, antibody, rev up the immune system, the NK cells fight it. And so is there a way that you can rev up that immune system a little bit better so they fight it a little bit better? And so there was some work that was done by a scientist who is at St. Jude now, and she's currently in Washington, D.C. And what she did is she took some natural killer cells. Those are the white blood cells, the fighters that make this work. That's on the left, of healthy donors. And then she took some tumor cells, that's the PDXs, put them into a dish together, added some antibody, and then added different things to see if you can make them kill better. And so what she found is that in the first box, that on the top, when you add IL-15 to this chemotherapy, or excuse me, to the natural killer cells and to the antibody, that more of them kill. In that case, kill the tumor cells. Those are the black bars. And that then when you add on the far right, add that in with the IL-15, even more of them are killed. So it was a signal that maybe if we add IL-15 to our treatment backbone, that maybe it would be more effective. So she went on and she actually looked at it in different mouse models and combined different regimens. And so in general, the combination was using chemotherapy, so typically irinotecan temozolomide antibody is what a lot of people go to because it's been proven to be effective in clinical trials. So that's what she studied. So in the first group, in this case, bars going up means that the mice are not doing well, their neuroblastoma is progressing. Bars going down mean that their neuroblastoma is going away. And so in the first group, just chemotherapy, the mice all had progressive disease. And the second group, when she added irinotecan temozolomide antibody and GM-CSF, a few responded, but many didn't. The third group, she added an agent we used to use, which was IL-2, which is kind of the same idea in Alice Hughes' paper to rev up the killing of the tumor cells. And again, some went down, but others went up. But when she combined the chemotherapy with the antibody therapy and IL-15, tumors regressed in the mice. Again, they're mice, right? But it's a signal of activity. And so when we were looking, this is a trial we're currently working on, when we were looking at what is available, there is an IL-15 superagonist called N803. It was previously called Alt-803. And it's been studied in adult patients who have non-Hodgkin lymphoma and a few other types of cancers. And basically, what it does is when you give it, again, this is in the first adult study, it makes the NK cells, the fighters, go up. And then importantly, some of these cells on the bottom, it doesn't really make those go up. And those cells on the bottom I'm not going to talk about, but sometimes we think that they kind of counteract why the chemotherapy and the antibody don't work as well. And so the patients that were treated on this study, in this adult study, had a good response. They had few side effects, and the most common just being some redness around the site of injection that wasn't an infection. It's not like cellulitis is the fancy word for calling it a skin infection, but more just kind of redness and those cells going to that spot but not causing an infection and otherwise tolerated. And so recently there was a trial in adults with patients who have non-Hodgkin lymphoma where they combined this with another medication called rituximab. And what they found is that when you give the N803 in combination with rituximab, again, down means response, that patients who had received rituximab previously alone were having a response. So this is kind of the basis of this next study, which is called Honeybee 803. So Honeybee 803 is going to be a new trial that's coming soon, looking at chemoimmunotherapy plus IL-15. So this will be a first in pediatric study, and what we're going to do is initially there's going to be what's called a safety phase, which is where we combine irinotecan temozolomide, the humanized antibody, and the N803. We're going to make sure that you can safely give these together. If you can, then we're going to go into a phase 2 study in which patients will be randomized to receive either chemoimmunotherapy, so irinotecan temozolomide, humanized antibody, or the chemoimmunotherapy with the N803. And we'll try to determine if the addition of N803 helps. And so where this trial currently is, the antibody for this study is manufactured at St. Jude, although that was recently acquired by a drug company and announced this week. And so the antibody is manufactured at St. Jude. It will start at St. Jude, but then this trial is going to be conducted through the consortium NANT, which I think a lot of you have probably heard about before, and I know Araz is going to, Dr. Marcellian is going to get up and give a talk about the NANT consortium. It will probably open in the spring, fingers crossed. And so with that, all of this work is really a collaborative effort with colleagues both at St. Jude and then, of course, colleagues all across the world. And so these are just some of the people that really contributed a lot to those trials. And then, of course, funding sources. And then it all comes back to the fireman and the dancer for me. So again, when I think about 2007, when I started my fellowship, and see those Kaplan-Meier, those survival curves coming up, I know that we are doing better for patients like them, but we have to continue to push it. And we need your help, and we are there for you. So with that, I'll take questions.
Thank you, Dr. Frederico. Anyone have questions? Okay, got one.
Hi, good morning. Thank you, Dr. Federico, for your amazing overview. With the success of dinutuximab, specifically when paired with chemotherapy, what has the discussion been, and has there been any discussion in the medical community about kind of curating a randomized trial with chemoimmunotherapy versus something like transplant?
Yeah, so this is like the $1 million question that keeps us up at night. There are a lot of things that keep me up at night. Neuroblastoma is definitely one of them, and this is one of the main things, is that we as a community would love to start eliminating some of the toxic aspects of therapy. The question that was asked earlier, like, what are you excited about? I'm excited about the fact that I do think in this kind of like next phase of my career and our careers, that I think the paradigm's gonna change. But we have to do it through careful studies. Because really, and again, I'm like a big believer in chemoimmunotherapy, mostly because like those 64 patients, like I knew all of them, like I saw them get better. And so I'm a big believer, but it was one institution that also has a lot of supportive care and other things, right? And so I hope, are gonna change the treatment paradigm as more progress is being made. The COG, the Children's Oncology Group, is really thinking about what that next trial will look like and how best to evaluate if you can replace, it's not get rid of, it's replace transplant with other therapy, and how would that best be studied? And so there are a couple of investigators who are actually looking at potentially what that next study would look like, Naveen Pinto and Jenny Foster, who are working on that. So very, very important. When I looked at the list of other people that are coming up, though, there's been a lot of progress that's being made in other cellular therapy, and it's going to be a matter of figuring out where you should put some of these treatments, how you should change them up, and then the million-dollar question is, who do we give what therapy to? So the unfortunate thing that really keeps all of us up at night is that we still do not know which patients respond to what therapy. And so unfortunately, we are certain that we are over-treating some patients. Some patients probably don't need the whole cassette that we give. But unfortunately, we just don't know who those patients are. There's no way to identify it. And so, one of the biggest, an important aspect of these clinical trials is really trying to learn more about the biology. And there are a lot of correlative studies, fancy word for trying to figure out like how the body is responding to these different treatments, that are built into these clinical trials, so that hopefully in the future, we're not quite there, but hopefully in the future we know which patients should, okay, you're responding great to chemoimmunotherapy, that's great, carry on, let's do that. Maybe we can eliminate or replace transplant with some more of something else, but you are not, and so you should get this other therapy. And in some ways we know some of that, or there's more progress that's been made, like with ALK inhibitors and the exciting data that Dr. Goldsmith will talk about tomorrow. But for many we don't. And so my hope is that in the near future we can answer that question. And there are a lot of people working really hard at how we can answer that question in a randomized trial, so that when we get to the end, we can feel confident that whatever the results are the results.
Another question?
Hi, we go to CHOA. Dr. Cash is our doctor.
And he's the best.
Yes, you probably mentioned my name, he'd be like, oh, yeah, I know them. But I don't know what he would say, but we did have the immunotherapy, and it was kind of rough. We only could get it while she was in the ICU, because they had to monitor her blood pressure, because at one point it made the blood pressure extremely high, and then all of a sudden it made it extremely low. And so, like, one of the side effects was now that she has extremely low blood pressure all the time. And I was wondering, was that one of the side effects? Because it has never normalized after that. It's always extremely low.
Yeah, so you are 100% correct in that there are a lot of side effects associated with these therapies, and certainly blood pressure shifts and fluid shifts can be related to antibody therapy. It's also hard, though, to know when our patients have received so much other therapy previously to be able to tease out, like, oh, this is definitely related to this specific drug, because sometimes I think it's actually a combination of the therapies that you have received. So in this case, yes, you can have swings in your blood pressure, but I don't know your child's specific situation, so I wouldn't be able to comment on that, but there are definitely side effects, and it's also why it's important to be at centers that can evaluate and safely administer the medications. Not all patients are in the ICU, but definitely there are some that in order to safely receive it, need to be in the ICU. Other questions?
Another question?
First question, first question is more for clarification, but the trial that had the antibody on the induction stage, all those chemos looked familiar, but were those the same chemos that are at the COG?
Yeah.
And same doses and all that?
Yeah, so I didn't get into that in detail. So that 6-cycle regimen was what was used in a COG trial that was conducted in the early 2000s called AMBO2P1 that added the first 2 cycles, cyclophosphamide, topotecan, as the first 2 cycles. And then the same backbone, same doses was also administered on the next study, AMBO 532, which looked at single transplant versus tandem transplant. Since that time, subsequently, the COG has gone to a 5-cycle induction based on work that was conducted by Megan Granger, where she gave the 5 cycles of induction, dropped the 6th cycle, and then looked at the response, so PR or better at that time point, and compared them to historical controls, and they were the same. And the idea and the rationale behind that was, well, if we're thinking about adding tandem transplant, do we really need all the same 6 cycles of induction? So now the subsequent CLOG trials do a 5-cycle induction. It's also why I pointed out differences, though, and I think as parents, this is so important for you to ask, again, when people are presenting data to you, like, well, were there differences in that study? It doesn't mean that they're a bad study, right? But like, what were the differences and kind of what were the rationales? And really get a sense of, are we comparing like apples to apples, apples to oranges, or like apples to broccoli, right? Like, because it's not always clear, to be honest.
Yeah, and then the next question was just kind of what the logistics of that looks like. I know that, I think of induction, you have like chemo, then you have a few weeks off, and then chemo again. How that logistics works with the antibody part.
Yeah, so in the COG trial, so how it worked on NB 2012, the humanized antibody being added, is similar to how it will work on 2131. And so the patients start their chemotherapy on day 1. It's still a 21-day cycle-ish. And the patients will then start the antibody treatment concurrently on days 2, 3, 4, and 5. So they'll get it for those 4 days. The plan is always to run it over the 10 hours, which is the common way that dinutuximab is administered. But then, of course, depending on different clinical situations, if someone has a virus or maybe their blood pressures are a little bit more sensitive, of course, sometimes it can be extended out to run over 20 hours. The other difference there is that the injection that normally patients will receive pegfilgrastim or G shots to boost their counts after they get chemotherapy. The injection when you give chemoimmunotherapy is a little bit different. It's what we use with antibody therapy in general, so GM-CSF, which I'm sure many of you are familiar with.
Okay. You had a question here, and then we'll go to the one further.
Thanks. My question is, early in your presentation when you were speaking about the adding Dynatux and the 3-year event-free survival rate, did that include or not include children that were on a clinical trial after the standard COG protocol? For example, like my daughter did the traditional COG protocol from 2017 to 2019, but then went on DFMO. She didn't make it to the 3-year event-free. So am I saying, I don't know if I'm saying that clearly, but
I think there are a lot of different questions.
Okay.
There.
The 3-year event, adding the Dynatux looked like a positive. So it was like, I think it was 53% had got to the 3-year mark event-free. So were those 50?
Adding dinutuximab to the end of therapy.
Right.
Okay.
Sorry. So
No, that's totally fine.
if you added the Dynatux at the end of their COG treatment, standard treatment, and the 53% went on to have 3-year event-free survival, did those children participate? Were you including any children that participated in a clinical trial? Does that make more sense?
Oh, so it's a great question.
Okay,
I
sorry.
just wanted to make sure, no, it's perfect. I just want to make sure I was following it. I think there are 2 things that I can say about this. So number 1 is about when we add other therapies after treatment, like DFMO, vaccine. There's lots of data about those things. And so if I'm understanding your question correctly, it's when we look at numbers, did some of those patients get vaccine? Did some of them get DFMO? The hard part is that we don't always know. So, it's a little bit difficult when you're collecting data. It centers around the country, and people have to put in their information, but sometimes if a patient has gone on to another center, you might not have all the information. Maybe it didn't always get uploaded. So it's a little bit hard to know like what that percentage of patients that may have been included on that. I think you do also though bring up an important point, and this is 100% my bias. Okay, so I want to own my own biases. That I would love to see. It would be great to see some sort of trial that looked at, well, what if those therapies that go on after the completion of treatment, to really be able to learn and randomize them and tease out the effectiveness of them, because we still just don't know. Yeah.
One more question?
Yes, thanks. So I kind of wanted to tail off of his question earlier with the human 1418 adding the antibody, and like my understanding, it was like all 5 cycles that the human 1418 was added, yet later on when you were talking about the CH 1418, the first 2 induction cycles were, standard induction, and then adding the Dynatux for the latter 3. So, and maybe you explained this already. I mean, is it like, I guess like the side effects between human and chimeric versus like, will there at some point be a comparison of, 5 cycles with human 1418 versus chimeric? And
Yeah, so there are a couple of questions there. There are points I want to address. So you are right, you 100% got it. So at our single institution, where we just were able to control a lot more because you're there, we did give it with all 6 cycles, and it was a different antibody. In the COG pilot study, 17P1, it was just given in cycles 3, 4, and 5. And again, that was just due to concerns at the time of, can we safely give this at institutions elsewhere, because just people weren't used to giving chemoimmunotherapy. In the upcoming protocol, 2131, the antibody will start in cycle 4. So it'll be, 2. So it'll be 2, 3, 4, and 5. So they'll get it in 4 cycles. And again, the reason for that is just that there's concern with how sick some of these kids when they first arrive, that if we gave them antibody, that maybe we would cause significant harm and they wouldn't be able to tolerate it. So that's why it started in cycles 2, 3, 4, and 5, or done in cycles 2, 3, 4, and 5. The million-dollar question of, can you do a randomized trial and compare antibody to antibody? If you let the investigators in the room write whatever study they wanted to, I think we would all run that trial. But it's complicated, right? Because sometimes people don't want their products like compared head to head, and then it just gets complicated. And so I don't imagine in the near future that would be the case.
okay, thank you so much.
I know you said one last question, but
One quick question, because we get to break.
to piggyback off what I said, okay, you guys knew that the blood pressure thing was a problem. Well, why wasn't I informed? And like, what it does happen after you take this drug and you have those issues? No one follows up and say, okay, this is how we correct the blood pressure problem, because every doctor that we go to with these blood pressure problems, they don't know how to fix it. And it makes her with low energy. She sleeps all the time. She's tired. How do we fix this low blood pressure problem that this therapy caused?
Yeah, so first of all, I'm so sorry that your daughter is having all these side effects related to therapy. I think all you can do is what you're doing, which is reaching out to people and having her seen by people that are trying to understand it. Unfortunately, sometimes we just don't understand the exact mechanisms and even what medication contributed to that. It's also, though, why it's really important for us to, on these clinical trials, collect that, right? So then we learn, even though it doesn't help your daughter right now, we learn about some of these side effects, and it can inform future trials. But I can tell you that I think probably all the physicians have had many experiences where sometimes we just don't know why a specific symptom or specific side effect of therapy is happening, and we're not good at being able to predict that. We may in the future, as we get more of these different, blood samples and conduct different correlative studies, be able to tease out some of those patient populations that might have some side effects, but we're just not there yet.
Okay, all right. Thank you, Dr. Federico. Okay. We are pretty much right on time, so if you want to take a 15-minute break, we have some snacks and stuff in the other room. Thank you.